in the follow-up session. I'm sorry that I had to miss it, the initial session yesterday, but followed closely the PowerPoints, and very appreciative of David Mealy presenting this rather complex but very fundamental topic. So with that, I'm going to forward this back to David so that you can kind of follow up from where you left off and also answer the questions that people have submitted. So thank you, everybody.
Thank you, Carolyn and Monica. Yes, we've got a few comments and questions that have come up, so I will, in good time, make sure we address that, and then remind everybody that if you have questions, comments, disagreements that come up, even as we're speaking, feel free to put those in the chat and send it to all participants, and we'll make the best use of our hour together. I wanted to follow up on some issues in applying the concepts that we talked about yesterday, and just to re-emphasize some points, and then relate those to the questions and comments that came up. So I'm going to start off with reminding us that in treatment, it's important, if we're trying to engage people in a self-change process, to really start with what the participant is at action for. And when I say action with a big A there, I'm sort of referring to the trans-theoretical model of Prochaska and DiClemente: pre-contemplation, contemplation, preparation, action, and maintenance. In other words, anybody who has agreed to go into treatment and agreed to be a participant in drug court or any specialty court is motivated. And we want to approach them as if they are motivated, but for what are they motivated? And to really take the time to find out what is it that's most important to you, and not let people get away with saying, they made me come. So the reason for doing that is because that's what you're going to hold them accountable to. Anytime they are acting in a direction opposite to what they're most motivated for, that's a good opportunity to not beat them over the head with it, but to point out that they are veering in a different direction from what they said was most important to them. But you can't do that unless you've first identified what they're at action for, whether that be getting on probation or getting the kids back or completing drug court and getting everybody off their back and so forth. A second point I want to reemphasize is that self-change and lasting positive change can't be mandated. You can't just mandate perfection from the court any more than we can mandate non-psychosis, non-depression, non-anger, non-suicidality, non-mania, panic disorders or anything. You can't mandate perfect blood pressure. You can't mandate perfect blood sugars. And so it's really important to mandate assessment and treatment adherence, where the accountability is around good assessment, and then making sure that real treatment is happening and that the person is adhering to the treatment plan that they helped develop. So of course we would love people to be perfect and be able to mandate that, but self-change that's going to really be sustained has to be what is engaged upon in treatment. Another important point is that smooth, positive progress is very unlikely. That in most chronic illnesses, especially addiction and mental health, people rarely embark on the path to recovery by just ever onward and upward, perfectly moving without any flare-ups, any setbacks in their progress or any poor outcomes, and just go on to full recovery. That's very unusual. I've never really seen that in my clinical experience, in the last 40 years. And it's normal to have these sort of flare-ups. So if we understand that that is going to happen, then the focus should be on requiring an assessment of what went wrong and then changing the treatment plan. And if the participant is willing and able to change the treatment plan in a positive direction, then treatment should continue without sanctions for shaky outcomes like using or not going to meetings or sort of outbursts or even mental health signs and symptoms. The final point I want to just emphasize before we get on to the questions and comments is that dropout prevention doesn't just mean allowing a participant to passively sit in a program and do time. You know, you might say, well, we can prevent dropout if we just let them stay here. And maybe they'll have a spiritual awakening, maybe they'll gain something in the period that they've been mandated, so we'll just kind of hope for the best. No, it means holding each person and participant in treatment accountable to their discovery plan if they're at that stage of change. And if they're not in good faith making an effort to be in treatment, then as we've talked about before, sanctions are appropriate for not a poor outcome in their treatment, but because of a lack of good faith effort and not doing treatment. So sanctions are a part of a dropout prevention plan. Sanctions are to get the attention of the person to say, you are now out of compliance with the court order to do treatment that you agreed to do, and the fact that you're here sitting in the program doesn't mean that you are doing treatment. And so getting their attention is a part of helping them to stay engaged and not to drop out. Now, let me move on to some of the questions and comments. I'm going to sort of just read them first and then go over a few other more concepts and then circle back and try to apply those concepts to the issues and questions raised. Here's one that says there's great concern at the Bureau of Justice Assistance, and actually Carolyn Cooper raised this, about the racial disparity perceived in both the demographics of drug court participants and the arrestee populations, as well as in the demographics of who appears to successfully complete the drug court. And then she asks, any thoughts on how we can address this? You know, unfortunately, we don't have a lot of data on this, but that is being worked on. I mean, do we need to look at that disparity and make sure that we're addressing criminogenic issues such as employment or peer support? What do we have to do with successful engagement and completion to make this happen for some populations that don't seem to complete as well? So we'll get to that in a second, and I'll address criminogenic issues in relationship to the ASAM criteria multidimensional assessment. Another question came up, given the rework a caseworker takes on to re-engage a client to help them want to change and take the steps to change, is there any occasion that will result in a client being terminated from a therapeutic court? We'll circle back on that. In the post-webinar survey, these were some comments and questions. I often get questions from people who are about to reconcile a discovery dropout prevention plan when dealing with a judge who is mandating abstinence regardless of the client's stage of change. Judges do not necessarily understand or agree with this model. We'll address that. And then one individual said that they wanted to create a discovery dropout plan template for their agency to be used with clients in early stages of change, but they need more information on the items to include in this. We'll give you some thoughts on that as well. And then finally, in response to the question about additional information, somebody would like more information about cultural specific issues to African Americans. So keeping those questions in mind, I just want to review some things that have come from our first webinar, actually. That is, we are trying in treatment to do individualized clinically and outcomes-driven work, where you have the cycle there, which really starts off with multidimensional assessment, then goes to identifying the main problems and priorities to be focused on in treatment, looking at the severity of illness, but also looking at a particular person's level of function. So we're looking at strengths and skills and resources. And then we want to collaboratively work with them on an individualized treatment plan that involves a variety of modalities, a variety of evidence-based practices, a variety of strategies, and do that in a level of service that is the least intensive but safe level, and then to track progress and outcome by looking at severity of illness and level of function and making sure that if it isn't going well, that we assess what went wrong and change the treatment plan based on what new problems and priorities have shown up in that multidimensional assessment. We won't go in detail, but remember, here are the 6 dimensions that look at a holistic assessment of a person's need to then develop an individualized treatment plan. And then tying this in with criminogenic factors, these are the common criminogenic factors that often get quoted: antisocial values, attitudes, antisocial behavior, and personality. And those are subsumed under issues in dimensions 3, emotional, behavioral, cognitive, under readiness to change, and recovery environment, who people see that they want to hang out with, and so forth. We talk about criminal and deviant peer association. That's a dimension 6 recovery environment issue. We talk about substance abuse. That is tied in with a dimension 1, acute intoxication withdrawal, with dimension 4, readiness to change, with relapse and continued use, and with dimension 6, if somebody's using substances and they're getting into criminal behavior to get the money to do that, or they're drug dealing. Those are dimension 6 recovery environment issues. And then dysfunctional family relations is definitely a dimension 6 recovery environment. So when we talk about should we be addressing criminogenic factors, I would say we need to just be doing holistic assessment, and you will, in the course of doing person-centered services, address criminogenic factors. We don't want to just focus on criminogenic factors, because that's not going to take into account many of the other things that influence whether you get a good outcome, things like employment, housing, things like trauma, things like physical health problems like chronic pain, and other things that can affect a person's functional well-being and contribute greatly to whether they relapse or continue to use substances. A couple of other things is then, as we develop that individualized treatment plan, we're looking at motivational enhancement and motivational interviewing. We're looking at care management. We're looking at the correct use of medications. We're looking at self-help, mutual help meetings and helping people develop a recovery support network. And then we're looking at making sure that we're continually monitoring things that are changing that may need a readjustment of the treatment plan, and then you have to do that in the continuum of care. So we shouldn't be mandating a particular level of care and length of stay, but really mandating treatment in a continuum of care that allows people to test out whether the skills that look good in a more structured environment are actually functionally really involved in a self-change process that the person will do in less intensive levels. So how are they doing in a community reintegration process? What are they doing in terms of housing and friends and money and so forth? And then a couple of other reminders before we get back to the questions. We talked about what we know about looking at what works in treatment. And that big yellow lemony part is extra therapeutic or client factors. If we're going to really help sustain change in positive self-change that is able to last beyond a program where we have them in a very structured environment, we've got to make sure that we engage all of those things that relate to the person's values, their friends, who they hang out with. This includes criminogenic factors, their family, their job, how they get money, look at their cultural values and any specific issues that are important to that particular culture or subculture. And then in treatment, to make sure that we're working with somebody in a therapeutic alliance, that they're in good faith, making all the effort they can, that we're providing a sense of hope with the work that we do, whatever models we're using, and then make sure that we're using evidence-based practices that are the best models and techniques. But remember, it's not just the model and technique that creates the outcome. It really is all of these factors together. And then I'll circle back to this to answer the question about discovery and dropout prevention plans, where I'll give you some thoughts about how you can individualize treatment in treatment plans and give you some resources about interactive journaling as well. All right, so let's go back, and then a reminder that if you have a question or comment, please feel free to type that in, and we'll answer that in addition to the issues that have come up. So, Monica, do we have a question or comment already?
No, not at this time.
Okay, all right, good. So let's go into this first issue here about the how do we involve criminogenic issues, and would that help look at the disparities between who gets arrested, who seems to successfully complete. And when we're talking, and this also ties in a bit with more information about African Americans, I think when we're looking at who doesn't seem to do well, what happens is often programs can be designed for a population that doesn't quite fit. For example, if you mandate people to go to AA, and many AA groups are more suitable for middle-aged white male alcoholics, and then you have people who may be African American or brown or yellow or whatever, that doesn't quite fit that group. Now, of course, there are many different AA, NA, and other 12-step groups. Whenever somebody says that doesn't quite fit, the first thing I say to them is there's many different groups, so please look around. Don't go to one meeting and then feel like that doesn't work for you, because you might find another group that really fits. But that can be one area where we are mandating AA for people who may have difficulties about the spiritual aspects of it. There may be difficulties in terms of the color of the people there, in terms of the socioeconomic group. And so if we keep our focus on individualized treatment and really look at what sort of recovery support group would work for you, it's great if AA works for them because they're much more readily available and they're so more widespread, and we don't want to not encourage people to try that out. But if it's clear that that isn't working for them, or that's not something the person even wants, we have to focus on where would you get the most support. Some people may get that from their community of faith, or their church, or their synagogue, or their mosque, or they may get it from some other sort of self-help, mutual help group like Smart Recovery. They may have co-occurring issues and do better at a Dual Recovery Anonymous group or Emotions Anonymous. So yes, we want to find out what are the demographics of the people who don't seem to do well. That will give us a clue as to whether we may not be addressing the needs of that population in our programs. But on another way, if we just keep focused on person-centered individualized treatment, tracking in real time, is a person engaged and are they getting better, you will address many of those issues that come up in terms of ethnic and cultural issues and other subgroups, because cultural issues are also different subcultures. There could be religious subcultures, there could be sexual orientation subcultures, gender identity subcultures, as well as ethnic and then socioeconomic subcultures. So that we want to make sure that you can subsume a lot of those sort of initiatives and sensitivities under the rubric of, do I really care about this individual and what are their particular needs in all of the 6 dimensions? So for each of those dimensions, there may be specific cultural issues that are important. and we related how the criminogenic factors relate to that. So for example, on dimension 6, recovery environment, there may be people whose support group looks quite different in one culture to another. And as I mentioned in terms of self-help neutral health groups, if you lump everybody into 12-step AA recovery, that may not fit for other people. There may be people who on dimension 3 for their co-occurring mental health issues get more out of prayer or spiritual or other alternative or complementary methods than just medication. There may be people who on dimension 6 have healers in their culture that are not necessarily traditional doctors. There may be people on dimension 2 where there are physical health problems of chronic pain. It isn't all about just medication. They may do better with acupuncture, or they may do better with chiropractors, or they may do better with nutritional approaches. So really each dimension can bring up different assessment needs for different people, and therefore in collaboration with them in developing a treatment plan, you may actually be developing a plan which is both culturally competent and gender specific and helpful in terms of their sexual orientation or their religious subculture and so forth. So should we be dealing with criminogenic factors? Yes, but if you cover all of the 6 dimensions, you will be addressing those factors if you really do holistic, individualized treatment. Now, let me move on and make sure we get through each of these, but I hope that others will tune in and let us know if there's anything I said that you disagree with or that you need more clarification on. Let's go to the second one. Given the rework a caseworker takes to re-engage a client to help them to want to change and take the steps to change, is there occasion when a client is being terminated from a therapeutic court? Well, yes. If a person is not doing treatment, if they're just sitting there doing time, and you then do a graduated sanction, and then that gets their attention and they recommit to treatment, and then they end up getting a positive drug screen, or they keep hanging out with friends who are not helping them to succeed, and then you say, well, this is not going well. What are you willing to do differently in your treatment plan? Which of those friends are you now ready to give up? Because we started off with you saying you can hang out with them with nothing bad happening. But bad things are happening. You're getting continued use, you're getting positive drug screens, you're being distracted by them. Which ones are you willing to give up? I'm not willing to give up any of them. All right, well, what are you willing to change your treatment? Are you willing to go to more meetings? Are you willing to do something that will help you to get a better outcome? Well, if the point comes where a person is not willing to change their treatment plan in a positive direction, and I mean really change it, not just say, okay, I'll go to more meetings or something. If they're not actually doing the work that treatment takes, and if you've made that treatment plan match their stage of change, then you have a right to say to them, you have a right to choose no further treatment. So I call that sort of termination not we're kicking you out for non-compliance. You're choosing not to continue in treatment by your behavior, by your not readiness to actually make changes in a positive direction. We're not asking you to make changes to perfection. We're asking you to make tiny steps, progress, not perfection, as they say in AA. And if a person's not willing to do progress in a good faith changing of the treatment plan to address poor outcomes, then the treatment provider has the obligation to say to the court, this person is not in treatment. And I recommend that we terminate them from drug court because they've terminated themselves. Now, firstly, yeah, we have
just
questions
real
or
quick,
comments?
we do have a question, and this is from Ms. McNeil, who had asked the question on the previous slide, and she says, how far do we need to go for language-appropriate services for group/other activities identified in a treatment plan?
So you mean ethnic issues where people can't speak the language? Is that kind of thing, I assume?
Yes, she says yes.
Okay. Well, I think this is always the balance about what are the limits of our resources. And if we had unlimited resources, of course, we'd say let's get all the services that a person needs to get a good outcome. The realities are we probably, we don't have unlimited resources, and you might have to decide there's going to be some disadvantaged people who only speak Spanish or only speak, Vietnamese or something, and that we can't serve them. Now, of course, if we find that this is a repetitive issue, that we're not addressing the needs of a population that keeps coming up, then we have to look at, we have to apply those resources. If we're talking about, 1 in 500, you might have to say we just don't have the resources to be all things to all people. Whenever we don't have the ideal, at least write down in a form that takes 30 seconds. This is what I would have liked to have done. This is what we had to do because of the real world, and here are the reasons that we can't meet their needs, and then what's the outcome when we can't meet their needs. So I would have liked to provide specialty language translation. What ended up happening is we couldn't accept that person to treatment. The reason is we don't have resources for translation, and the outcome was this person reoffended and cost us more because we didn't do what could have been done earlier. Then you have some way of looking at systems gaps and seeing what that costs in terms of human costs, but also in terms of money and criminal justice resource cost. So at least turn a frustrating situation that you may not be able to fix at that moment into a data gathering opportunity to identify what are our biggest gaps in the system, what would be the best return on investment if we were to invest funds in that. And since we don't have unlimited resources, which are the biggest priorities to invest funds in to get the best return on that investment? All right. Well, I go on. Nothing else yet, Monica?
Go ahead.
All right. So the next one is I often get questions from people who want to do discovery drop prevention, but the judge who's mandating abstinence regardless of stage of change. Yeah, so this is a very common issue. We wanting to talk more and more with all the important stakeholders around the table, and of course judges are one of the most important stakeholders, and we want to attract them into recognizing that if we're going to get the outcomes we all want, we have to treat addiction the same way that we treat other chronic illness and the same way we treat it in mental health courts. So this is a matter of education. It's a matter of recognizing that the judge may be at pre-contemplation for having discovery dropout prevention plans, not because they're evil, but because they just don't know what they don't know, because they're not understanding what stages of change means in terms of really engaging a person in a self-change process that's going to have sustaining, lasting, positive change that then impacts the public safety and likelihood to reoffend. So we have to be respectful of everybody around the table, recognizing that we are coming often from different lenses and perspectives, but just as important are the probation officers and parole officers' perspective, the judge's perspective, the treatment provider's perspective, the participant's perspective, child protective services. All of those are important stakeholders, and recognize that if we're not getting good outcomes, if we're getting 50% of people dropping out of drug court, if we're finding people don't actually, quotes, complete drug court, if we're finding that people end up completing and graduating, but then a significant portion of those reoffend, all of those are outcomes that are not good. And rather than saying, well, we'll just keep doing what we've always done and mandate abstinence and then sanction for positive drug screens, we might need a new paradigm. We might need to take responsibility for those outcomes not being good and not just blame the client and the participant. And too often that's what we've done in the past, is we blame the victim, we blame the participant for being non-compliant when really we didn't do a good treatment plan. We didn't provide the kinds of services they needed, or we mandated perfection when this is a disease where you can't be perfect. If you can be perfect, you don't need treatment. So the webinar that we're going to do on April 27 is from 11 to 12:30 is how do we get there from here? So we want to address some of these issues. And just a reminder while I'm thinking about that, Monday, April 18, we're going to be having a session from 1 to 2:30 Eastern Time on relapse, continued use, or continued problem potential. And then on April 19, from 1 to 2 Eastern, challenging cases. So if whoever wrote this, if you actually have a case where this comes up, it would be great to actually look at, here's the situation, here's what the judge was thinking, how would we work as a court team and a treatment team to really encourage a different approach from just the standard mandating abstinence and then sanctioning for that? What stage of change was this person at? How could we have engaged that person? So I would love it if, rather than just that overall question, we had a case that really, and ideally, what's wonderful we've done in other situations like this is to have all of the court team listening in and having a chance to talk back and forth and agree or disagree on how we would approach somebody who's at an early stage of change. So just a heads up, challenging cases April 19, and it would be great to apply these concepts to a real case. One individual said they wanted to create discovery dropout plans and a template. So let me just give you some thoughts about that. Now, whenever I hear the word template, I always get a little anxious, because what often happens is that people pay more attention to the template than they do to the participant. And they pay more attention to what looks good on paper than what is actually meaningful to the participant, because any treatment plan should be based on a collaboration with the participant and the client on what they are willing to do and what they think will work or not, and what they're willing to put energy into. So you could have a perfectly looking template that addresses things that looks good, but if the client doesn't relate to it, then that's not a good discovery dropout prevention plan. But having said that, because people have a struggle with, well, what do you mean? Here are some sample strategies for a treatment plan. And I offer them to you not in the sense that, well, these are the only ones you should use and this is the template, and so just pick from Chinese menu A, B, and C, you know. It's not that kind of approach. But this is to give you a flavor. Now, a good treatment provider should be able to develop with the client an individualized problem, goal, and strategies, which is what I mean by a discovery treatment plan. A discovery treatment plan, remember, just to remind you, is if somebody's interested in recovery and is ready to do whatever it takes. My life's unmanageable, I'm sick of being arrested, I'm sick of being in prison, I'm sick of having no money, I'm sick of having my life be in turmoil, I'm ready to do whatever it takes. A treatment plan is really easy. You go through the 6 dimensions and you look at each of these dimensions, where are you shooting yourself in the foot and what would you change to get into full recovery. Then you develop that treatment plan. That's a recovery relapse prevention plan. But most clients who come through drug court and other specialty and problem-solving courts are not at action for recovery. They're at action for getting people off their back, or for doing less time, or for getting their kids back. So those people need a discovery treatment plan, and by that we mean a motivational engagement process where you say, well, what are you willing to work on? and here are some strategies. List 3 reasons the court sent you to treatment. If somebody comes in and says, you know, thank you for being here, why did you choose to come to? Well, I didn't choose, they made me come. Well, what are they worried about that they would send you to an addiction treatment or mental health or co-occurring disorders program? What are they seeing that makes them think you need treatment? Well, I don't know. Then if they don't know, that should be part of the discovery plan. List 3 reasons the court sent you to treatment. And how are we going to do that? Well, we better meet with your probation officer, we better meet with your family, or we better meet with the person who arrested you, or ask the judge what he or she is seeing that makes them think treatment will then provide a better chance for public safety. That would be a discovery plan. Now, if somebody says, well, they think I have an anger problem and a substance problem and a, you know, criminal antisocial attitude problem, great. Then those are the things that they better work on if they're going to actually demonstrate real change. But if they don't know, then that could be a strategy in the discovery plan. Write down the most recent incidents involving alcohol or other drugs. That might be somebody who says, well, I don't really think I even have a problem with addiction. I can stop any time. Well, then let's see what the most recent incidences were with alcohol or other drugs. And you know, you got a 3rd DUI, and you got arrested for a drug-related assault and battery, and you got, you know, let's get specific about what's going on. Identify what happens if you don't comply with probation requirements and report to group, and indicate which consequence is worse for you. So this would be a discovery plan around, do they really know what will happen if they don't actually start to make some changes? And if the worst thing they're thinking was, well, I really don't want to do more time because I just have a new relationship, I hate being locked up, well, then that's going to be an important thing that they're at action for. How do I not do more time? And then whenever they are doing behaviors that are moving the opposite direction, you can point out that discrepancy. List the positive and negative aspects of substance use. You'll notice that it says the positive aspects of substance use as well as the negative, because you want them to be honest about, well, actually, it relieves stress and it helps me zone out, or it makes me the life of the party, or whatever it is. If it still has a lot of positive aspects, that's important for them to work through instead of just pretending they're ready for recovery. List the positive and negative aspects of being in treatment. What would you get out of treatment, and what do you hate about being in treatment? You want them to open up about that. Attend at least one AA meeting and see if you can identify with anyone's story or not. You give them permission to say, that didn't do anything for me. Or, I didn't really identify with everything, but there was one person who said that they, for years, didn't think they had a problem, and that kind of sounded like me. Verbalize in group what things need to change in your life or not. Somebody might say, I don't think I need to change much at all. They're just overreacting. Discuss the positive and negative consequences of continued substance use. Again, if I was to continue using, what would be good about that? What would be bad about that? Explore early child history of violence or trauma through individual therapy once a week, and focus on what kind of role models you had. Were all of the role models, this is how you cope with life by drinking and drugging, or this is how you cope by life with slapping people around, or this is what I experienced in terms of sexual or physical abuse. For the next incident of rage and anger, fill in a form that says, what date did I do this? What triggered it? How did I feel? Did I get red flushed in the face? Did I feel like knots in my stomach? Did I just have muscle tension? And then what behavior did I do? I punched somebody, or I threw a chair, or I yelled at them. And then discuss how you could have de-escalated that rage. Let's walk that back through and see what point you could have intervened to not have it escalate. And please share in group what has been working to prevent relapse or continued use, and get other suggestions. Now, I said what's been working to prevent relapse, because you can't really have a relapse unless you've first been in recovery. So it might be just continued use, but you've been able to not continue to use, and how did you do that? And then get some more suggestions. So these are some examples of strategies that could be in a discovery plan. Any questions or comments, Monica, I need to take?
Yes, it looks like we have a comment kind of question from Mr. Nicholas Foss. He says, I think this idea of a discovery/dropout prevention plan is absolutely fantastic and makes so much sense if we are using motivational interviewing in stages of change. I'm just wondering if you have developed or could create a template. A template maybe of general aspects of those types of plans that we could refer to on a PDF document or Word document. That way we can start getting along the same lines of thinking with examples, maybe a book that gives specific examples.
Mm-hmm. So what I just did in terms of strategies and treatment plans is part of a discovery plan. In other words, it's having strategies that match the person's stage of change. If you were going to have a recovery treatment plan, it would be go to a meeting and get a sponsor. That would be a recovery plan. And that would be great if the person loves AA and is ready in their stage of change to get a sponsor. Or it might be, in a recovery plan, might be change all of your friends and develop new positive friends who support recovery. That would be great if the person recognizes all my friends are a disaster for me in terms of being reoffending. And so we often see those kinds of treatment plans mandated from the court or by a treatment provider, and they don't fit most people's stage of change. So the sorts of things I just gave you. In terms of a template for dropout prevention, what I would encourage you to think about more is to think through the 6 dimensions of the ASAM criteria. In other words, what's going to cause this person to get troubled to the point where they just can't take it anymore and they just drop out. And this could be on dimension 1, where somebody is in withdrawal and they need better help to be able to manage that withdrawal, and that might mean methadone maintenance strategies. It might mean buprenorphine. It might mean medication that, if they're in actual withdrawal management medication. What might help them not to drop out is on dimension 2. If they have a chronic pain problem and they aren't getting the kinds of support through physical therapy and real attention to their chronic pain problem, they have an urge to use, and they end up using somebody's medication, get a positive drug screen, drop out, and it's because we didn't adequately assess dimension 2 and help them. It could be dimension 3, where you're really looking at missing their trauma or a co-occurring mental health problem. And then if a treatment program has attitudes about giving people psychotropic medication, or they don't have the staff to work with co-occurring disorders, that person's going to drop out because their needs are not being met. A person's going to drop out on dimension 4 if they are having all recovery relapse prevention plans when they need motivational enhancement. So if a treatment program is confronting somebody and getting them to change aspects of their life that are way ahead of where the person's at, you're going to create discord, as they say in motivational interviewing, and actually you're the cause of them dropping out because you're coming on too strong too soon. It could be because of dimension 5. We've not given them enough supports about how to deal with cravings to use. Perhaps they need antabuse. Perhaps they need naltrexone. Perhaps they need acamprosate or Camprel for alcohol craving. In other words, medications may be part of what would help a person to deal with dimension 5 issues, along with other strategies to help them deal with coping skills and triggers. And then dimension 6, they might be worried about money. You might have a treatment program where you're saying to come here, you have to give up your job, or you have to tell your boss you're not going to show up, and that's going to mess up their work schedule. And you actually want to support them continuing to work and work on their recovery. That's where they're going to have to work on the recovery in the real world anyway. So we want to support them in in helping them, if they can, keep functioning as much as possible, as well as getting treatment. We want to work with family or significant others. They may have a relationship that they're troubled about. They may have childcare problems, or they may have issues to do with transportation. So really, when you think about a template for dropout prevention, we're really just talking about how do you actually do treatment that is going to give a person the best care that they can get, and not left undone things that are going to flare up. And for that person, it might just get overwhelming. If they're having chronic pain or they have emotional problems and we're not addressing these things, we're just pushing AA and we're not thinking about medication, and we're not individualizing the support groups, and we're not addressing all of their dimensional needs. So that's what we mean by a dropout prevention plan versus a recovery relapse prevention plan. Relapse prevention plans are easy if a person is ready to embrace recovery. You just have to look at the dimensions and they're ready to do whatever it takes. Most people are going to need finessing in terms of that individualized treatment plan. And then the discovery part of that is sort of what I went through with some of those individualized strategies. Comment to come back at me at? Monica?
Just with a thank you.
Okay, all right. Okay, so let me proceed with, we talked about some of these strategies in terms of discovery plans, but again, this has to be individualized. Don't just take these and sort of plonk them into somebody's treatment plan if that's not meaningful to them. Now, I want to tell you about interactive journaling, and I want you to know I don't get any royalties from these, but these are such an important resource from the change companies that I just want you to be aware of it. Interactive journaling itself is a evidence-based practice. It's on the National Registry of Evidence-Based Practice and Programs website, and some from SAMHSA. And one of the 200 or so different journals or workbooks is the Drug Court Journal, and I gave you the link there. If you go to the change companies, you can see a few electronic pages of this. And this is to address when people say, can you give me a template for a discovery plan? Well, the whole idea of interactive journaling is to incorporate evidence-based practices of cognitive behavior therapy, motivation interviewing, stages of change work in a facilitated, guided self-change process where each page in the journal is really for the client and the participant to interact with this. And so I just want you to know, if you're not aware of these resources, the Change Companies has had a many years experience with the Federal Bureau of Prisons and has many criminal justice journals. There's the Courage to Change that can be worked with probation officers working with their supervisees, the Drug Court Journal in drug courts, and a variety of other journals. And if you go to the Change Companies, you can look at a few electronic pages of each journal and get a feel for what it's about, or better still, call them up and say what population you're working with and get some guidance on which journals might fit that. So I don't want you to think I'm just advertising. Of course I am advertising, but it's really to make sure that people get the word about this is a resource that would help you do some of this work. You don't have to just start with a blank piece of paper. You can build on 30 years of experience with interactive journaling and really match journals to your client's needs. Question, comment? Monica? Looked like Nicholas was back up again.
Yeah, Nicholas says, any more interactive journaling workbooks for treating disordered gambling?
There is a gambling journal. I'm trying to remember what it's called. I think it's called Safe Bet. Again, if you go to the Change Company's website and try Safe Bet or gambling, or if that doesn't come up in the search bar, just give them a call. But there is a journal for gambling disorder, yes. And there are journals for adults and children and adolescents as well.
It looks like that was the only question for now.
Okay. Now let's see. The final one that I think we haven't addressed yet was cultural specific to African Americans. And so as we think about who does well in drug court, who doesn't do well, and we're finding that if there is an overabundance of arrestees who belong to a certain group, and African Americans has been, I think, demographically part of that group, and if we're finding, and I don't have the data on this, so that's why I'm saying if you're finding that they're the ones who tend not to complete or quotes graduate, I mean, I talked before about my discomfort about the whole concept of completing and graduating, because if somebody really has the disease of addiction, they may do a piece of work in drug court, but we really don't want to give them the impression that they've completed or that they've graduated from doing anything more. We really want to link them to ongoing resources and services depending on what their needs are in terms of severity. But if we're finding that African Americans are part of the subpopulation that doesn't do as well in drug court, that's a very important issue to look at. And I mentioned one area that I think could be part of that problem, and that is mandating 12-step AA meetings for people when there may not be enough meetings that where African Americans and Asians and others may feel comfortable. So that we both need to try to encourage the development of 12-step groups that are more inclusive, but also recognize that if a person doesn't feel comfortable there, where can they get the equivalent support? So the focus in talking about AA should be, well, here's AA, it's easy, it's more readily available, and the reason I recommend it is because where else can you get a coach who's willing to have you call them 24/7 and listen to you if you're having a hard time? I mean, there's not many sponsors in AA that I would have ever heard of who would say, just call me between Monday and Friday, 9 to 5. Sponsors are there for you. So we say, where else can you have a support group where people can be there for you? Where else can you have a support group where when people are sort of living it up at St. Patrick's Day on New Year's Eve or Mardi Gras and getting totally wasted, where you can be with a group of people who can have fun sober? Where else can you get a support group where you can go every day and more than once a day if you need to? If not AA, that's fine, but then how do we help you to develop those kinds of supports that will fit to your particular needs and perhaps to your cultural needs? So that's one area. In terms of, treatment, we again want to be aware that, again, in any of the 6 dimensions, there may be issues that may be more specific to African Americans and to Asians and to other cultures. But whenever we're talking about cultural competence, be aware that you can do kind of reverse discrimination. I don't know if that's the right term, but I often use the example of myself. I was born and raised in Australia, but I'm full Chinese. And if you saw me, you would say, well, here's an Asian. I'm culturally competent. I know how they are. Well, you actually would be wrong with me because I'm a banana, yellow on the outside and more white on the inside than I am Asian, if you get my drift. And so we want to make sure that whenever we're looking at culturally competent issues, that we're not stereotyping people and that we're taking into account what for this particular person are the issues in these 6 dimensions that make a difference for this particular subculture, whether that be an ethnic subculture, religious, spiritual subculture, sexual orientation, gender specific, and so forth. Now, I don't know if the person who raised that question is on the call, but if you have more follow-up about that and had something in mind, I'd love to hear from you. Or if anybody else has experienced more with some of the changes you've made to be more culturally sensitive and competent with African Americans, let's share the wisdom. So feel free to jump in there.
David, it's Monica. We actually have a question, and I was wondering if you could repeat it as well. The website you referred to with evidence-based practices, which website is that?
So at the bottom of the PowerPoint, you see www.changecompanies.net.
Mm-hmm.
So the Change Companies is a company that has been around for 25, 30 years, where their whole focus has been journaling and the power of people actually writing in the journal. So in the journal, and you can look at a few electronic pages, you'll get a flavor of all different titles. I think there's about 200 different titles. You know, one's on anger management, or one's on, you know, life skills and personal health and gambling, and then there's the drug court journal, which is specific to drug courts. If you look at a few electronic pages, you'll see that it's laid out so that people can interact with the page. That's why it's called interactive journaling, not computer interaction. And it will ask things like, why are you here? What do you want? Get people to draw pictures, and you know, for people who may not be just looking at writing things, but the interaction with the page is found to be very healing to people, and it is their journal and their particular system of understanding that you can individualize the treatment through the journal. And then there are facilitated guides for the journal that helps the clinician or the facilitator know how to use each page in the journal in an individual session, a group session, or as a homework assignment. And then we even did a research project where we just handed out a journal, not the drug court journal, but just handed out the journal to people who were in prison, and they went through it themselves, and they had a lower reoffending rate than others who didn't get that. So interactive journaling is a very powerful process, and William Miller of Motivational Interviewing is the senior advisor at the Change Companies. He was the one who really got the application into NREP. And so I recommend you taking a look at this, because there's been a lot of experience with criminal justice populations in interactive journaling. So changecompanies.net, and if you can't figure out the website yourself, just give them a call. But they're not going to pressure you. They can walk you through what journals might fit your population.
Perfect.
Just to remind you of some other resources on motivational interviewing, and then these websites I was mentioning, changecompanies.net, but asamcriteria.org there's some free resources there, journal articles, and more e-training modules on the ASAM criteria, tips and topics. If you'd like to get my free monthly newsletter, Tips and Topics, the latest one that I did in March is all on what we've been talking, not all, but a lot of points that we've been talking about in these webinars. So if you go to tipsandtopics.com, you'll see the latest edition and can sign up there. Make sure you don't have good spam controls, otherwise it'll go into your junk mail folder. Or you can search 13 years of back issues and get information there. I've done on treatment planning as well. Or if you have a question or comment, feel free to email me. I want to really be a resource to help you actualize some of these principles. All right, I think we're out of time, Monica. Anything else that you want to say, or Carolyn?
No, it looks like we are out of time. I just want to mention that we will be emailing out the recording from yesterday and today's webinar, as well as the PowerPoint slides in the next couple of days. And keep an eye out for the announcements of our next session. The next one is going to be on April 18th at 1 p.m., and then we're going to do another challenging case session on April 19th at 1 p.m. So if you have any cases that you're coming across that you'd like Dr. Mealy to address, please go ahead and just send those in to justice@american.edu. And Carolyn, is there anything else you wanted to wrap up with?
No, I just wanted to thank Monica and David for for the session. And just to let people know that we are planning to try to get kind of a succinct summary of each session that we can kind of highlight the principal resources in some type of a fact sheet, so people who haven't accessed the webinar themselves will at least have a resource. So we're working on this.
Okay,
so thank you, everybody, and I hope everybody has a nice rest of the day, and we look forward to being back in touch on our next session. Thanks.
Thanks very much. Bye-bye.